Now we're going to see Parkinson's disease. Parkinson's disease. Parkinson's disease is the degeneration of cells or neurons on the substancia nigra. The other subset of patients in which they have Parkinsonism, so the disease is not directly this. The disease is, the pathophysiology is there is vascular infarct that leads to Parkinsonism. This is vascular Parkinsonism. Or this could be due to other things that damage neurons, like carbon monoxide, magnesium, cyanide, trauma. This would be pugilistic Parkinsonism, like in box. And there are myriad of things, abscesses, etc. Encephalitis, in many ways. Alright, now, in Parkinson's disease, this is due to the degeneration of the substancia nigra. Clinically, the patient would present with, let's say, this mnemonic trapped. So, tremor, rigidity, I would say abnormalities on the movements, like bradykinesia, PF posture instability, or postural hypotension. This is when the patient goes from a seated position and then stands by. The patient will have this postural hypotension. And the T is just in order to have the trapped mnemonic, so it could be T or anything else that you find. So we have tremor, a low tremor, 4 to 10 hertz, slow tremor, most of the times 4 revolutions per second, and the rigidity on post on tremor is Cowell rigidity, and this is the presentation of Parkinson's disease. The abnormalities on the gait is the patient would be doing everything very slowly, so would walk in many steps, would take a lot of steps to give the turn, and the patient would be a little bit flexed, and you would not see the normal swinging of the arm. This is the fascinating gait seen on Parkinson's disease. There are some Parkinsonism syndromes, like She-Drager syndrome. This is, let's say, Parkinson plus postural hypotension, or he is very frequent the postural hypotension, or that the patient is falling a lot. This is the classic thing. If we see a patient in which it is falling a lot and has Parkinson, we should think about She-Drager syndrome, that is also called multisystem atrophy. Here the patient presents with this. Also could be some signs of lower motor neuron and pyramidal tracts, etc. If the patient has ataxia, you will also think in this, that is ataxia plus Parkinson, you say olivopontocerebellar atrophy. And here the patient presents with, could be some kind of dementia, but the memory and intelligence are preserved. There would be some aspirations syndrome, and the patient would have degeneration of the cerebellar cells that would lead to ataxia. And if the patient has upper gaze palsy plus Parkinsonism, then this is supranuclear palsy, progressive supranuclear palsy, in which the main feature is Parkinsonism plus inability to look upward. And the patient will also have, for example, let's say, pseudobulbar affect. This is the inappropriate crying or laughing, independently of how the patient's emotional state is. That is, could be telling some story of a very painful history, and the patient would be laughing, for example. Also, the patient would have dysarthria, dysphagia, increasing the reflexes of the jaw reflex and gag reflex, and a myriad of things. So, now the Parkinson's disease could present usually at a low grade. Let's see the grade. 1, 2, 3, 4, 5. 1. The patient has bradykinesia, tremor, and rigidity. 2. The patient has troubles with speaking, gait, and there will be deterioration of the reflexes. In 3, there is the same as 2 but worse, and the patient has bilateral and worsening of the things. But the patient continues to be independent of the gait, for example. And in stage 4, the patient is now dependent on other family members to walk. And 5, the patient is confined to a bed or wheelchair. So this is Parkinson's disease, and sometimes this can lead to dementia. Remember that if the dementia presents before 1 year of Parkinson's disease, then this would be called Lewy dementia, and we will also see other symptoms of Lewy dementia. But if the patient has Parkinson's disease and years after present with dementia, then it is dementia due to Parkinson's disease. And in the brain biopsy, we will see alpha-synuclein inclusions. Alright, now let's go to the treatment of Parkinson's disease. There are also surgical treatments in the worst of the cases, but here we're going to focus on the medical treatments. So we have here is dopamine and here is dopa. So dopa is converted to dopamine on the central nervous system, but also dopamine on the peripheral nervous system. Dopamine could be converted here in the central nervous system to 3,4 dihydroxy phenylacetic acid, or also called DOPAC, or into 3,3-methoxytyramine. And here DOPA can be converted also into 3-methyl-DOPA. So, what do we do in order to increase dopamine coming to the central nervous system? We can block this conversion of dopamine, this central nervous system conversion of dopamine to 3-methoxytyramine. This action is by the COMT enzyme, catechol O-methyltransferase enzyme, the same enzyme that catalyzes this DOPA to 3-methyl-DOPA, COMT. So this we will block it with tolcapone. And entacapone and tolcapone both will block the peripheral enzyme, and we will have higher DOPA, higher concentrations of DOPA, and so higher levels of dopamine on the central nervous system by blocking this and by blocking this. Tolcapone blocks both. The other is to block this. This is by the enzyme MAO-B, monoaminoxidase B enzyme. So we block it with selegiline or rasegeline. The adverse effects would be insomnia and confusion, something like that. And this would decrease the need of give, for example, direct DOPA. We have also amantadine. Amantadine will increase the release of dopamine and will decrease the reuptake. The adverse effects of these include, let's say, libido reticularis, in which there is vasodilation of the blood vessels. Also, this can lead to venostasis and long-term also telangiectasias. Next we have dopa. We will give levodopa. We will not give directly dopamine because dopamine cannot cross the blood-brain barrier, so they will be useless. So we will give dopa, and the dopa then will be converted into dopamine. We will give dopa, and we will give something that will decrease the conversion of dopa to dopamine on the peripheral nervous system. This would be carbidopa. So we give levodopa and carbidopa. The adverse effects include hallucinations, confusion, nausea, postural hypotension. The nausea is due to levodopamine on the peripheral nervous system, on the vomit center in the medulla. So when we give carbidopa, we're blocking the conversion of dopa to dopamine on the peripheral nervous system. We are decreasing also the adverse effects of levodopa. So we are decreasing the nausea as an adverse effect. Now, here is something that we call the on-off phenomenon. Here, the on-off phenomenon is there are periods in which the patient is like moving, walking, and then is like freezing or cannot move. Then, as time goes by, then the patient can walk again. So, the patient has this due to these medication fluctuations on the dopamine levels. If we give, for example, the COMT inhibitors that are not given alone, but we can decrease the fluctuations of the dopamine levels and so decrease the fluctuations of the movements of the patients. And lastly, the direct agonist of dopamine. So we will give a agonist of the receptor of dopamine. These are Pienrol and pramipixole. Also, we can give gabergoline or bromocriptine, and here the adverse effects are kind of the same as with dopamine: hallucinations, confusion, nausea, postural hypotension, but something important: gambling. Gambling with this, gambling with that, and the patient takes a lot of risk. Could be fighting with the wife, fighting with the boss, or just going to do bets like in the Vegas or something like that, betting all the money or something like that. So gambling, let's say gambling syndrome, is seen when the patient is taking these drugs. So we already reviewed the Parkinson's disease, the manifestation, the Parkinsonian syndromes associated, and Parkinson's treatment. If anything of this works, we can also give surgical, let's say, burning or stimulation. Stimulation in high frequency stimulation means damaging, and we will damage some nucleus of the basal ganglia, like the globus pallidus.